Okay, it's 10:37. Committee Member Anderson, we are ready to go if you are.
All right. Welcome back from break, everybody. We will turn the time back over to Staff Member Davis and the subject matter experts for immunization protocols.
All right, Amy, what do I need to open next?
Yes, so we will be, our next presenter is Grishelle, and we will start with hepatitis A.
Get it open.
Okay. Good morning, everyone. My name is Grishelle. Thank you for another opportunity to present to you all. The first protocol that I will be presenting is the hepatitis A vaccine. So starting off with the What's New section, per the Twinrix package insert, the latex hypersensitivity warning and precaution was removed. So I just reflected that in the warnings and precautions section of this protocol. The immunization protocol section, nothing really has changed there. In the vaccine schedule, just wanted to emphasize again for the pediatric vaccine that the minimum acceptable age for this vaccine is 7 versus 1 in the FDA approved age range, which is listed below.
Grishelle, I'm going to interject really quickly. Committee Member Gibbler has his hand up.
Okay.
I just, thank you. And this is Committee Member Gibbler. And just on these tables, this spacing on one of the tables is 1 month. And that's a question I've gotten in the past from pharmacists is, does 1 month equal 4 weeks? 1 month can be 28 days or 31 days, and pharmacists can be particular about that.
Yeah, thank you. I do believe we caught that elsewhere, and anytime it was 1 month, we changed it to 4 weeks. So I would recommend that change. And then if it was greater than 1 month, we use the months spacing rather than the weeks spacing. So we should see, anytime it would say 1 month, I agree, it should say 4 weeks.
Staff Member Davis, should it be 28 days? Because down below you say days.
So that's because those were less than 4 weeks.
Okay.
Yeah, I mean, whatever the committee wants to go with. We can go through and change them all to 28 days, but I believe 4 weeks is consistent. And then if it was less than 28 days, it'll say number of days. Once it hits 28 days, it'll say 4 weeks. And then if it goes longer than that, it changes to months.
Yeah, that's not, none of that's relevant since every week is 7 days. It's just the months.
Okay.
Question.
Thank you for that. I'll make sure that is corrected for the final. All right, moving on, licensed vaccine section. Nothing has changed there. For the recommendations for use, It is the same language used in the previous protocol. Nothing has changed as well. In the contraindications section, no change there. And as mentioned previously in the warnings and precautions section, I just removed, or the Twinrix vaccine was removed for the hypersensitivity to latex. Other considerations, no change there. Side effects and adverse reactions, no change. And then for storage and handling, I added that upon storage, a fine white deposit with a clear colorless layer above may be present, and to shake well before use. This was not previously there, so I added that. And just updated for references, the package inserts. And that is all for the hepatitis A protocol.
We
Steph-
do.
Yeah,
Oh,
go ahead.
sorry. This is
Go ahead.
subject matter expert Valdez. We're missing the Fahrenheit conversion like we have in all the other ones in that storage and handling chart. So let's make a note for that.
Okay. Perfect.
Staff member Davis, I just saw two things while we were scrolling through and I just had a question. So in 5B, there's commas at the end of each of these, so it kind of reads like a rule to me. Like, should this say like and at the end, or should these be periods? Should they not have a punctuation at all? It just looked weird to me that it had a comma. So I'm just gonna.
Yeah, I think it came out of a list and I agree, just remove the commas.
So I'm just gonna put a question mark there.
They're each independent of each other.
Yeah.
They don't have to have multiple. And actually it says anyone that wants to get a vaccine can get one.
Thought I saw one other thing, but it was something little like that. It wasn't a big. Oh, I do like that these are linkable in this one, and the ones we were looking at earlier, they didn't have the links.
Okay.
And I think that's very helpful for pharmacies if they're opening it up in real time. They can just click.
Love it.
So as you're modifying, those are minor changes that can be made. All right. Did the committee have anything? Oh, sorry, I was looking at the notice. Okay. Okay. What's next?
All right, so what's next will be the hepatitis B vaccines.
Just a second. Okay.
All right, so for the hepatitis B vaccines, one of the major things is that we wanted to combine the pediatric and adult Hep B protocols. Just like hepatitis A, how it mentions both pediatric and adult, we felt that there was really no reason to have separate protocols for pediatric and adult Hep B vaccines, so it's all included just in one protocol for pharmacists to reference. All right, for vaccine schedule, just trying to make it more consistent in the labeling of the tables and the vaccines. making it more consistent of how it looks like in the hepatitis A protocol, just adding the title or the name of the vaccines and what they're used for, pediatric versus adult. And in terms of wording for minimum acceptable spacing, in the previous protocol, it would say going from dose 1 to dose 2, 4 weeks, dose 1 to 2. I simplified that to just 4 weeks. And then going from dose 2 to 3, it used to say 8 weeks, dose 2 to 3, and 16 weeks after dose 1. I felt that it might be a little confusing. So I just simplified it to 8 weeks and 16 weeks after dose 1. Let me know if you have any suggestions on whether or not we should go back to the previous wording or to just keep it simplified like this. To me, it made more sense and wasn't as confusing as before. All right, and then additionally, there used to not be a section for pre-Hevbrio vaccine, but it's included here. It used to just have its own line with an asterisk, but it is now included here just for completeness and consistency with all the other vaccines listed. Now going down to licensed vaccines, I noticed in this draft for Engerix B pediatric formulation and Recombavax pediatric formulation, the minimum FDA approved age should be birth instead of 7 per the package insert. So that should be birth.
And pharmacists give this committee member give like pharmacists give vaccines to neonates. I mean, it's in the protocol. Is that confusing?
No, but for the acceptable age up there, it says 7 to 19, but we just wanted to
Okay.
show
Okay.
the difference.
That makes sense.
Mm-hmm.
Yeah, all the protocols include the FDA approved range. And so that's why that change just didn't get caught to match that up to the actual approved instead of the protocol age, which was 7.
Right. Yeah. Okay.
No neonates, but we'll talk about that subject later. Coming up, coming soon.
All right. And then for recommendations of use, again, just changing the wording between the multiple doses, trying to simplify that. Alternative pediatric schedules, nothing has changed there. We took into account spelling out microgram, so that way it's more clear for ISMP purposes. Then Twinrix, all the accelerated schedules and dialysis schedules, nothing has changed there.
This is committee member Gibler. On these tables, can we, again, just for consistency, when it says 1 month, just change it to 4 weeks. And then if it says 2 months, I would suggest saying 8 weeks. Anything higher, I don't think is relevant, but it would be helpful for pharmacists, I think.
Yes, I will make sure that any 1 month there says 4 weeks, just for everything to be consistent.
Regarding the 2 months comment, I agree that it's applicable to 4 weeks because we have that consideration of how you space vaccines, and particularly for live vaccines, there is 28-day spacing versus if you said 1 month, that could be 30 days or that could be 31 days. I'm not aware of any products where the spacing comes into play at 2 months, whether that was 56 days or 60 days. I'm not aware that that would offer any clinical consequence.
That makes sense.
So that's
Okay.
kind of why we went in that direction, and kind of only being more specific with the 4 weeks because it is mentioned as a specific interval.
Yeah. Okay, thank you.
And even the CDC is not consistent with 4 weeks versus 28 days, but I think as long as we're consistent, it's fine.
I don't care about weeks versus days. It's mainly just not saying 1 month.
Yeah.
This committee member Myers, I just looking at the CDC catch up and other schedules, they do tend to go with 8 weeks instead of 2 months. It's when you get to 3 months that they start using months. So if you were to be consistent with what most of the CDC says, I think it's 8 weeks, but
Okay. We can go through and look for those opportunities.
I'll just tag it once. Okay.
And I will, this is Committee Member Gibler, I'll just tag on to that. That could be helpful, even though it's not clinically relevant. That I've heard that comment before, that they wish that even said in the 2-month intervals, they would just say 8 weeks if that was appropriate because of what the CDC outlines.
Perfect. We can do that.
All right. In this section, I know previously in the last protocol, there are semicolons here. I don't know if that was something that we wanted to remove as well. Since it is a list.
I think it's the same comment as we had earlier. You can go in and just do the cleanup there.
Gotcha. Okay. All right. Other than that, the wording, no, and there were no changes there. Contraindications, no change. And the vaccine components, no change. Other considerations, no change. The side effects, no change. For storage and handling, just like Hep A, the fine white deposit was added. And then we'll add the Fahrenheit at the temperature there for the storage.
It's just
Go ahead.
Committee Member Gibler, sorry, I didn't know if I was called on. Just going, the vaccine schedule, does when you talk about those intervals after dose 1 and dose 2, I wonder, just because I'm not maybe as quick as others, but it took me a couple of seconds to understand what it was saying. I think it's saying 8 weeks after dose 2 and 16 weeks after dose 1, and et cetera, all the way down. Would that be more clear if that was written out, or is it clear to everyone already in it? maybe just me.
That was the original language, Grishel, from OHA, and you condensed it. Is that what you were talking about in the beginning? Or was it different?
Yes, that was the original. It was saying between 2 to 3. Doses 2 to 3, but we can add after dose 2. I think that would make it more clear. I agree with that suggestion.
Okay, thank you.
This is subject matter expert Valdez. Just a question for the committee. So the OHA protocols in the list, you know, they all have titles, and it's going to be the same when they come over to the board. OHA had Twinrix in the title of the hepatitis A vaccine, but not B, even though Twinrix was an option. So we went ahead and titled both of them that way. But I don't think the vaccine name needs to be in the title. So my suggestion for the committee would be that we just title these hepatitis A and hepatitis B. And just like any other product selection, Twinrix is an option. I don't think that would be confusing for pharmacists to know that Twinrix is an option. I don't think it needs to be in the title.
This is committee member Anderson. I would agree with that. That's kind of along the lines of a lot of things in pharmacy that we don't use brand names in titles, at least.
Yeah.
Staff Member Davis, I did notice one thing when I was looking at this versus the last protocol we were looking at is that you've included the brand names here, and it wasn't included in some of the other protocols in this section. And I didn't know if there was a reason, and some if it was like just an inconsistency or if there was something specific.
So I think originally we included brand names if there was some differentiation between the products. So sometimes there is something, like in this case, the ages are different between the different brands. And then I think as we moved along, it seemed like that appeared to be an inconsistency by sometimes it being there and sometimes not. So I think that's a good question for the committee to consider, making that consistent. There is a reason sometimes for it to be there and sometimes not, but would it be easier and would it be more consistent to just always include it, since sometimes it does need to be there?
Committee member Gibler, I think the trade names probably should be in there for consistency. Because,
Okay.
like I said, for the same reasons, and I think we refer to vaccines primarily by their trade names. One exception, pharmacy world.
Yeah, so I think we do have some inconsistency. I think when we started, we were trying to minimize use of the brand name when it was not needed. But then as we went along and we had more protocols where we needed it, it kind of looked like it wasn't consistent. So among our group, we probably have some inconsistent use. So we can go through and match all that up.
Okay. Anything else on Hep B? What are we opening next?
We're going to be changing presenters. So I will have C introduce themselves, and we're going to be opening the IIV flu protocol.
Oh, okay.
Turning it over to C.
Hi, I'm C. I am a new pharmacy resident with Fred Meyer, and I'll be presenting the next couple of protocols to you.
Okay, I think we're ready to go.
All right, so first starting with the inactivated flu, what's new? So we've updated the components for what ACIP has recommended for this year's group of vaccinations. Other than that,
Smee Valdez, can you just speak to this comment
Comment?
that you had? Yeah.
Sure, I just made a note because when these protocols that we presented to you were drafted, we actually did not have an OHA protocol to work off of. The OHA protocol was issued the day after we submitted these to the committee. So that was just a placeholder note to look for any other inconsistencies. So I actually have the OHA protocol up right now, and I'm going to be looking for those, and I'll call them out as we go through. I did take a brief look, and initially I don't see anything to call out, but if I come across something, I will bring it to the group's attention. So
And that theirs was issued after the ACPI recommendations came out. So we have those because I think their protocol is still posted as an interim.
the ACIP or the OHA?
Well, your note is about we expect ACIP.
Yeah. I do not see I am looking and I still see 22, 23, but it must be out because where else would OHA get that? So I'm going to have to dig a little. Maybe it was approved in meeting minutes but not published yet. But when you go to ACIP right now, all it's showing is 22, 23. But there must be one. Otherwise, I don't think Oregon would have been able to publish theirs. So
Well, they published it as an interim, and that's why I was
Okay.
wondering. Yeah, like they're essentially doing what you did. Like you created something, but we don't have the final ACIP yet.
Yep.
Okay. So just thinking through what we talked about earlier with timelines, can you kind of before we really start going down this path, what is it going to look like, do you think, in August each year? Like are we going to have to convene the committee to approve an interim and then reconvene to approve a final and then do that with the board as well?
So I guess the big question would be, I don't think it's typical that there's a lot of difference between an interim and a final. So yes, I do think the committee is going to need to convene in, around the end of July to update the protocol. I would suggest if there's not changes between the interim and the final, that I don't know, that's the committee's business whether they need to meet again, but we don't typically see changes between the interim and final.
Okay.
Mostly what they are updating is the strains. That's the biggest update. The other, and of course they're waiting for, there's also a separate process that we're not seeing, which is also FDA approval of the new whatever products are going to be on the market, which is kind of happening in the background. So potentially if a product did not meet that approval, there may be names of products removed, which could be a potential other change. And then the other thing that we look for is whether or not ACIP is going to recommend one product over the other. So for example, they started recommending officially through ACIP that people 65 and older need to have the high dose or the adjuvanted vaccine. So those recommendations could potentially change. And then the other thing that could potentially change is how they deal with children under the age of 9 that need 2 vaccines. It has been very consistent for several years in a row now, but potentially ACIP could change those recommendations. So really it's kind of looking at those 3 things. The strains, are there any like special, one product over the other? And, what did they do with children under the age of 9? So that's what we'd be looking for each year.
Okay. So potentially 2 meetings, but it might be just one to approve a protocol. And if there's no changes that ACIP necessitates further revision, then it would just stay the one that was issued.
Yeah.
Okay. It's helpful. Thank you.
You're welcome.
Back to our other subject matter expert.
Yes, and just for a little bit of follow-up on that, I did find we did the current recommendations that are listed here for the components of the vaccines. There was the CDC on June 29th adopted ACIP's meeting recommendations. And so until that's officially published, which looks like it's usually the end of August, as is noted, that's, yeah, that's what we're going off of.
Okay.
All right. So subject matter Valdez already mentioned the ACIP recommendations for adults over 65, recommending the high dose inactivated vaccine or the adjuvated vaccines. And then that all persons 6 months older and older with egg allergy should receive influenza vaccine. And this is any vaccine, whether it's egg-based or not, that is otherwise appropriate for the recipient's age and health. That is all for what is new.
Committee member Gibbler.
Committee Member Gibler, do you mind if we just eliminate those indefinite articles A and N before each lineage and these bullet points? It's confused.
Yes.
I mean, it's just
Yeah,
kind of muddy.
sure.
Thank you.
I think that's probably a cut and paste vestige. So, yep, perfect.
Almost done. Okay.
All right. As far as immunization protocol, it's just been simplified to remove things that are non-flu specific or for all vaccines. And then
I'm happy to speak to that note, see if you would like.
yeah, go ahead. That might be a little bit simpler.
So now is a good time to talk about this, and Staff Member Davis can jump in. So when currently we're operating under PrEP Act, which is authorizing us to administer flu and COVID vaccines. By us, I mean pharmacists, down to age 3. In the most recent legislative session, it was approved for pharmacists to be able to immunize for flu only down to age 6 months. So that is not reflected in this protocol. We don't quite have rules yet, but based on the timeline that Staff Member Davis presented today, those rules are going to take effect, I believe, January 1. That we probably should include in here to be ready for that, since we're talking about these coming into play in the new year as interim and permanent rules. We should include the 6 months age range in the flu protocol.
Yeah. Staff Member Davis, you said that perfectly. So it was 2023 House Bill 2278. It allows the board to write the rules now and to we can't take action until after September 26th, but we can't make it effective till 1/1. So I think that was also maybe a conversation for this committee and really you subject matter experts on you kind of do the heavy lifting in terms of revising the protocols. I threw out there earlier today for my presentation, like that you might want these adopted and moved through and to be effective 1/1. Considering, because I know you were doing these in groups, Amy, because of like when ACIP meets and trying not to have to like redo things whenever. I didn't know if 1/1, if you thought, and the committee could also, you know, obviously give input on, is 1/1 a good date or is 3/1 better? Because we're already changing like all the rules, like it's the middle of flu season to do 1/1, like what? For all of these, I mean, when would you want to see an effect? I can't promise effective dates because obviously the board has to motion and adopt, but like if you were to have your best preference, is there timing that works better? 1/1, 3/1, 5/1, like what works best?
And my thoughts on that have changed a little bit, kind of seeing a little bit more depth, especially what you presented today. I always thought 1/1 would be kind of a clean date, but based on what you presented today and knowing that the ACIP committee typically meets in February, and we sometimes don't see the new schedule and results until February. I feel like 3/1 could be just as appropriate. So I have no objections to 3/1 as effective dates.
And we'll obviously discuss with the board. I mean, it's a huge lift, all the rule changes that are happening already, and then moving this process at the same time. I don't know if that's helpful or overwhelming. So
Crystal,
we'll
do
have that
you
discussion.
Other thoughts? If these were all to switch over on 3/1, does that present any challenges in the practice environment?
Nothing that's specifically coming to mind.
We'll take that information back and discuss with the board when we get there. So.
And this is committee member Gidler. Are we going to leave the comment about the PrEP Act in there for any reason then?
But that's the OHA protocol currently has this statement. They frequently update their protocols and we don't see when they're updated. We, you know, at the state level, we don't speak to the PrEP Act. So I kind of went back and forth on whether this was appropriate or not.
Yeah, and I've had the same thoughts and thinking. So I think it is good to call out when something differs. So there's a few different things going on, and it is kind of hard to know what's in play. So normally for most vaccines up until very recently, our age was age 7, unless there is a and I'm paraphrasing, but there's a public health emergency. The governor and the Oregon Health Authority director can move that age down to age 3. That is in our current rules. And that's for all vaccines. The PrEP Act then came in and specifically addressed flu and COVID for pharmacists, trying to make it clear, especially in states that were more restrictive, that pharmacists can administer those vaccines to all pediatric patients. OHA added it to their protocol, and we left it in there just to differentiate why we might be immunizing below 7 is why we put that comment in. But obviously now we have this new information, and by statute down to 6 months. So I would say for the flu protocol specifically, I think we could get rid of the comment about the PrEP Act. If we're going to add in the information about 6 months, and by the time this is published, that rule will be in effect, I think we can eliminate the PrEP Act comment because we don't need to tell pharmacists why they're immunizing below age 7 because it's in statute now in Oregon for this vaccine.
Right. That was my hoping I would
Yeah.
you would respond that way, because that was a little confusing with that information there now. I do agree that it was helpful then.
Mhm.
And the Prep Act expires through 2024, so not
Yeah.
until, but I know this doesn't matter now, but.
So I would advise keeping the comment for now in the COVID protocol because it still does apply. And then we would remove it from this flu protocol.
Staff member Davis, we'll have to talk about that when we get to the COVID protocol.
Oh, okay.
Well, because the state can't direct someone to act under the federal guidance. You're either working under the state or you're working under federal. They're two different things. So we'll just have to talk about it.
We can talk about it when
cross
we
that
get there.
get there.
Yep.
Okay.
Turning it back over to you, C.
All right.
Sorry, we hijacked your presentation.
Oh, no worries at all. I'd rather everybody work this out now so it can get approved. All right, so as far as the vaccine schedule goes, the changes that were made there was just a little bit of rewording. So the OHA protocol mentions years 3 through 8, and then as a separate one mentions over the age of 9, to kind of differentiate that between 3 and 8, you might need 2 of those vaccines. We just made it so it's 3 years and up. Otherwise, look at the flow chart to see if they need 2, which is below. Then, yeah, no changes for the licensed vaccines. And then for recommended use, we just kind of simplified, actually, we added something there. So if we go down to, everything is the same except for C and D. If we go to C
I
and
do
D.
have one comment for A because
Yes.
that has been published, that we can change those dates in that chart to 2023. Now that's a screenshot, so we'll have to screenshot it again from. Yep. Perfect. So the recommendation is the same. ASIP has just updated the years.
Perfect. All right. So C and D here reflect what was originally 1 point on the OHA protocol. It's just going into more depth on egg allergy and which vaccines patients with egg allergies can receive. So C is history of egg allergy, can receive any license recommendation based on age-appropriate vaccine, but they should be supervised by a healthcare provider. And then D is addressing severe allergic reactions, noting that if you are giving flu block or Lucavax to anybody with a severe allergy, they should be prepared for managing allergic reactions, which also with C, but just pointing out that the difference there. For contraindications, no changes there. Just some simplification of point A. And to 7, warnings and precautions. Just removed some of the points that are non-specific for flu vaccines or pertain to all vaccines.
Committee
then-
member Gibbler has his hand up.
Yes.
Thank you, Committee Member Gibbler. Again, going back to any verbiage when we say healthcare provider, I'm still grappling with that this is a pharmacist, these are pharmacist protocols. So whenever we say healthcare provider, should we not just say pharmacist? Or are there, I know we're just copying language more broadly, but I don't know if that would just, I don't know who the other healthcare providers usually would be.
That is,
So,
yeah.
yeah, regarding the comments in C and D, I would say that historically, this has implied that if you're going to be potentially anticipating anaphylaxis, that it should be in a setting where, you know, advanced life support is available. And so typically pharmacists have referred people with egg allergy who have a severe allergy to more of an advanced setting. I don't know, Crystal or C, in your review, did you feel like this new language implied that these could be conducted in a pharmacy setting?
To me, on my review, it really seemed like they were trying to emphasize that if there's not a severe allergy, it can be given in any setting. However, it seemed like they were still precautioning that if the anaphylaxis is are higher risk, that it should probably be done in like office or something, like somewhere probably other than like the community pharmacy.
So, there is a little bit of difference between C and B. So C is talking about people who have egg allergy of any severity, which is a little bit more broad. And then D specifically calls out severe allergic reaction, example, anaphylaxis. So I don't know if we want to include that pharmacist part specifically on D. I probably would not.
As a
Since
committee
C
member, Gibler,
applies. Yeah, go ahead.
well, I agree with you. I just wouldn't include severe allergies as an option for pharmacists. I'm not sure how many of those patients are even getting a flu shot every year anyway.
Yeah. So do you like it how it is now where we call out the pharmacists? And I think actually what I heard you say, committee member Gibler, is maybe instead of saying healthcare provider parentheses pharmacist, since these are pharmacist protocols and they're in the Board of Pharmacy and they are no longer OHA protocols that other people are working on or potentially using in different settings. Should we just say pharmacist? Was that your suggestion? Like get rid of the healthcare provider? Yeah. So that's
in
another
our
question.
therapeutic protocols for medicines, we just say pharmacist. And so in our vaccine protocols, I think if we're meaning pharmacists, we just say pharmacist instead of making them really vague as a healthcare provider, because that just, some pharmacists just get a little confused by that and then ask questions to the Board of Pharmacy.
I actually like that suggestion, and even more so, I know when they were with OHA, even though they were pharmacy protocols, I think they used the same template for different providers, and maybe that's why they were so generic. I like that idea, and especially if they're going to be under the Board of Pharmacy, that makes sense to me.
And there's other protocols that use that language that we could just have to, like,
we'd have to search through, we would do that through every protocol and align it, and just anywhere it says healthcare provider, it would say pharmacist. So shared clinical decision making would say it's a conversation between the pharmacist and the patient.
Yeah, right. That's what I feel would be very clear. So thank you for bringing that up.
Staff Member Davis, on D, is that now like a non-permitted, something is not permitted in a pharmacy? Like, is that what the committee's direction is, that this must be supervised by a non-pharmacist healthcare provider?
I believe that was committee member Gibbler's sentiment, at least.
Yeah, and rewording it to say people with a severe egg allergy should be referred. I mean, just rewording the whole thing.
Committee member Myers has his hand up.
Yeah, Committee Member Myers, I was just going to ask, are there pharmacists who are able to manage a severe allergic reaction for somebody who's got an anaphylactic reaction?
We are prepared for anaphylaxis with epinephrine, and that is part of our adverse events protocol, is to be able to be an initial responder to anaphylaxis. I think the implication might be here that these patients are at higher risk potentially for anaphylaxis, and maybe should have faster access to advanced care. So, you know, we have EpiPens.
Yeah, I mean, I think you should be prepared for the unexpected and call, able to call 911 and get emergency responders there quickly, but have the ability to react. But if you think this is going to be an adverse event that is potentially expected, then I would think referring out makes better sense. And that to me would be why the healthcare provider language in this instance makes sense, because we want somebody who can manage this expected outcome. So either scrapping it as committee member Gibbler stated and rewording it to say be referred out, or leaving healthcare provider in this instance in, makes sense to me. Does that make sense?
Yes. I think what we're going to have to do is make some substantial changes to C and D, because D specifically is referring to flu block and Flucelvax. C is any vaccine. And so I think we need to clean that up. And what we really want to say is, if it's an anaphylactic type reaction, history of, that they're referred. And if it's any other severity, then it could be administered by the pharmacist. And so I think we need to make that more, I don't think it's clear as it stands now. So I think we can group together and rework both C and D to make that more clear for the intentions of the committee.
Committee member Gibbler, does that affect the timing to get this ready and the time that we need for it to get ready this fall?
This particular protocol, we also need to add the stuff about 6 months. So we're going to have to rework this protocol anyway, turn it around quick and send it back to you. I don't, Staff Member Davis can comment on what that means, whether you'll need to have a special meeting or not. But we're going to have to do the 6-month thing anyway. So adding this piece in wouldn't change that timeline.
So Staff Member Davis, if we were to wait to review these at the next regularly scheduled meeting of this group, that would be November, I think it's 15th or 16th, something like that. Then the board would not, you wouldn't be able to motion to send these for board review until the December board meeting, at which time the board would then potentially decide to send to rulemaking. We do not have a rulemaking hearing scheduled in January at this time. The next one isn't scheduled until May. That doesn't mean we can't create one if there's a need, but usually our rulemaking hearings are only held in May and November. So it would potentially push it out if we were to schedule an extra rulemaking hearing to address these protocols. really specifically, then the board could then adopt in February to be effective March 1 if that was what they decided to do. So we could either do a special meeting of this group or an extra meeting like in the month of September, or we could just do the regular meeting and then the board would have to schedule an extra rulemaking hearing. If they wanted them to be adopted before 3/1.
I can share with you that if you wanted to look at this again in September, we could turn it around with those pieces to you quickly.
Okay.
So
Okay.
it wouldn't be a problem on the subject matter expert end.
Okay. All right, we will continue through today and we'll continue this conversation because I think it will, like, as we see the volume and what's going on, we'll
Right.
be able to make some better,
Exactly.
decisions. Okay. Ready for C to pick back up?
All right. So not too many more changes on this one for you guys. Contraindications. There's just removal of 2 points that were, sorry, down to other considerations. So down to 0.8. Sorry about that. They're just removal of some non-specific points that are standard to all vaccines. And then section 9, side effects and adverse reactions, no changes there. Section 10, storage and handling, no changing in content, just some restructuring of the table.
Committee member Gibbler has his hand up.
Committee member Gibbler, just the adverse event table, the severe allergic reactions are, you just have 1.3 million doses. That's probably 1 per 1.3 million doses.
I am looking. Yeah, that's copied from OHA. Yes, that's correct. The edit is correct.
Where are we headed next?
A pneumococcal.
All right.
All right. So as far as what's new, there's no significant news with the pneumococcal vaccines. So then immunization protocol, that was just a simplification, taking out things that were not specific to this vaccine. And then 3 for vaccine schedule. What we did here was there's no new content. However, there's been some reorganization from the OHA protocol. So they had this information listed under recommendations. We felt that it was more appropriate to bring it up here to the scheduling. And then when we get down to recommendations, we added a little bit more to that. So that section is a bit more useful. As far as licensed vaccines, no changes there, except we did add that, oh, never mind, no changes there. All right, so and then for recommendations for use, so as mentioned before, that was previously those tables that are now listed under scheduling. Felt that some more information on different specific states would be more useful here. So some explanations that go a little bit more in depth from ASIP have been put in here for different populations. On to contraindications and warnings and precautions. No new changes there, just simplification based on consistent with the other changes we've been making across protocols. And then into other considerations. Let's see. There's just a couple of changes to clean that up.
Committee member
Yes.
Gibler has his hand up, excuse me.
Yes.
Thank you, Committee Member Gibler. What does, under recommendations of use, when you're going through that, under section A7, age 7 to 18, chronic heart disease A, 1, any incomplete series asterisks with PCV? What is the asterisk referring to? I can't find that.
I would guess it refers to something in the vaccine schedule. Let's look up there. But that if that is the case, it probably it should be mentioned in the chart, not. So that might just be a leftover asterisk. Looks like we do have a note in that table. If you want to just make maybe a comment there, like review. I'm not sure. Because the that table does have an asterisk, so I'm wondering if it was just we maybe moved some information from this section up to the table, which rightfully so. Like that's too much spacing to have a reference to an asterisk. So it might have been that we moved information up to the table, but we can double check that.
Okay, thank you. And then under same section, recommendations for use down on C, age 65 years or older, section F, again, it speaks about based on shared clinical decision-making, 1 dose of PCV20 at least 5 years after the last pneumococcal vaccine dose. Should we define what we mean by that?
Yep. So we can match that up to the other protocols. I think if you go up or maybe scroll down, is there any more on shared clinical? Okay, yeah. So we need to we'll build that out like we did the other sections.
It's only mentioned the one time.
And then the other comment I have is just in general, it's not more copy editing, but PP PPSV is sometimes referred to as PPSV 23 and sometimes just PPSV. It goes back and forth throughout the document. So if it title just refers to as PPS 20 V23, and maybe that would be a more complete way to write it out.
Mhm. I would say there might be some references where they're referring generically to groups, and if the PCV does not include the number, we don't need to include the number for the PPSV because it's referring to the class of vaccines, conjugate versus polysaccharide. But in cases
makes
like
sense.
this, where the number is included with the conjugate but not, then we'll match that up. That's a good call out.
Amy, I'm just pasting the CDC's job aid on clinical decision making with PCV 20.
Perfect. Thanks.
There you go. My head, I was thinking it might have gone away, and so I was making sure it still existed.
Yeah. I think we just forgot to copy in the considerations piece. Because it was not in OHA.
I think we were here. See?
Yeah, so other considerations, which we can actually just stay down there because all we really did was remove things that were not vaccine specific or pieces of information that had been more clearly stated before now, since we added into those recommendations more. And then down to side effects and adverse reactions, no changes there. Storage and handling, no real changes there, just removed information on multi-vial dose or multi-dose vials of PPSV 23 since it's not needed. So we'll be moving on to tetanus. All right, so nothing significantly new with these vaccines. The immunization protocol has just been simplified along the same lines as the other protocols. Vaccine schedule. What did here was added more information about the boosters. Just to clarify differences between adolescents, routines, and then additional ones. And then we also, the wound management table, we brought that up into this section from the other considerations. For 4 licensed vaccines, all we did was add presentation of the vaccines. For 5, added the recommendation of pregnant persons being vaccinated during their 3rd trimester. Contraindications, no changes there. Warnings and precautions, no changes there. other considerations, no changes there. And then, yeah, adverse reactions and side effects, nothing new there, and nothing new with storage and handling either. And then on this protocol, we have an appendix where we've added on the CDC recommendations for catch-up guidance for children 7 through 9 years of age, and then also catch-up guidance for children 10 to 18 years of age.
So one thing, this is subject matter expert Valdez. One thing I noticed in the wound management table, we probably need to define the TAG, tetanus immune globulin.
That's what I was scrolling back up there for, because I was like, what is it? But you have it here. I found it.
Oh, okay.
Yeah.
All right. That's good. Yeah, scrolling was happening fast, so I just wanted to make
Yeah.
sure that was included. C, was the appendix in the OHA protocol? I'm pulling it up now, but do you know?
Yes, it was.
Okay.
I went in and pulled, like, these are screenshots that I took personally, so any new information is reflected in there from what OHA might have different. But yeah, it's otherwise the same.
So we may want to address that the same way we address the appendix in the other protocols. They're escaping me right now. Which ones? The live vaccines. We decided to just put that in other considerations and not paste all the information that this committee would have to update. So unless, see if you can think of a reason why this would be anything unusual other than just using the catch-up schedule. I don't think we need to call anything out special here.
I don't believe so either.
Okay.
Where are we headed next?
We are headed to a new speaker. So thank you, C.
And I just want to do a quick time check. So
Yeah.
Lauren, committee member Anderson, it's 11:50. Do you want to proceed with the next speaker? Do you want to take lunch? Like, how do you want to?
Sure, this committee member Anderson, this does look like a really good time. It's almost noon. And we're between speakers. So let's go ahead and take a 30-minute break and reconvene at 12:20 p.m.
Great. Okay. Thank you so much. We'll see you all again at 12:20.